Thank you very much. First of all, can you all hear me okay? Can you hear me?
Yes, we can.
Okay, good. Just wanted to make sure. All right, and I just want to make sure now also you can see my slides. I should be sharing them now. Is that coming up okay on your end?
Yes.
Excellent.
Can hear you, can
well,
see
first
you.
of all,
go ahead.
Okay. Thank you so much for the opportunity to present at your esteemed meeting. This is a really terrific meeting, and I think a discussion of complications really relates to the cardiogenic shock therapy that we unfortunately face many complications in. And I hope to, in the next few minutes, just share some of the insights and learnings that we've had from developing a very advanced cardiogenic shock program here in Northern Virginia in the United States. Here are my disclosures. So over the next 15 minutes or so, I'd like to review the temporary trends, clinical outcomes, and treatment gaps that exist for cardiogenic shock. I hope to discuss the utility of and importance of cardiogenic shock staging, phenotyping, and hemodynamic evaluation that helps us match the particular form of shock to the appropriate mechanical circulatory support device selection. Finally, I'll describe the results of our own experiences using this matching of device to cardiogenic shock phenotype and stage that has helped us improve our outcomes, at least across a large swath of Northern Virginia, where we treat over 43 centers that send us patients. Suffice it to say that cardiogenic shock has been one of the most vexing challenges in cardiovascular medicine over the last several decades. For the first part of the millennium, for the first 20 years, we were sort of stuck on this 50% mortality associated with this very important disease. Now, we've made some headway, and I think we've cut down on mortality, but it took us the better part of 2 years since the first randomized trial, the shock trial, that showed improvement in patients who had myocardial revascularization when presenting with acute MI shock. Now, we also are starting to understand the long-term outcomes of cardiogenic shock. And this study from Canada tracked nearly 10,000 patients who presented with acute myocardial infarction, cardiogenic shock, and found very high mortality, not only early on, but a consistently high mortality in follow-up, being 50% at 3 years and over 70 to 80% dead by 10 years. So this continues to be an extremely lethal condition, and it's been exceedingly difficult to change some of these Kaplan-Meier curves over the last few decades. There are some insight suggesting that we're perhaps making a little bit of a difference, at least across the United States, with the current contemporary treatment algorithms. For example, this study by Osman in Journal of the American Heart Association over the last couple of years showed that cardiogenic shock incidence is going up. On the left, you can see it going up significantly in both forms, including heart failure shock and acute MI shock. But we're seeing mortality slightly decreasing over time from nearly 55% down to sort of 35 to 40%, with some regional variability that we see in the United States, such that there are different regions that have worse outcomes, in particular the northeastern part of the country. We're also seeing that cardiogenic shock is now a common cause of admission and mortality in standard contemporary coronary intensive care units. It's now in the top 3 or 4 reasons for admissions to modern CICUs. Heterogeneity in cardiogenic shock care and outcomes has been well illustrated and publicized in the past, and the heterogeneity can stem from many different factors. There's no real sort of generally and widely accepted treatment algorithm that's accepted across the country in the United States, nor across the world. And of course, outcomes may vary according to clinical characteristics of patients, including race, ethnicity, sex, where they show up in terms of the hospital, and many other factors. One of the great insights that we've made to understand how to triage patients and understand how to match care to the presentation has been the definition and classification of cardiogenic shock. I think most of us recognize and accept the definition of hypotension being less than 90 systolic blood pressure for at least 30 minutes, or need for supportive measures to maintain a blood pressure this high in association with signs of end organ malperfusion. I think that's a standard definition that most of us use and has been used in the clinical trials. There are hemodynamic parameters that can add to that. And of course, now we have the Sky Shock stages that have really helped refine our definition and help with prognostication. The Sky Shock classification being stage A, if you're at risk of developing cardiogenic shock; stage B, beginning of cardiogenic shock with hypotension, some tachycardia, but not necessarily hypoperfusion; and then stage C being more the classic form of cardiogenic shock with hyperfusion and hypotension, but not with deterioration; and then stage D and E being deteriorating in extremis patients that have extremely high mortalities. So this Sky Shock classification has been well validated now. I think it's generally widely accepted and used across multiple countries and multiple continents, given that it's got very good discrimination between patients who are likely to get to do poorly and those who are more likely to do well. And we can use this to help match the medical device therapy to this Sky Shock stage in order to deploy our resources most effectively. Now, another important learning is that we should understand the cardiogenic shock phenotype. That means, was the patient presenting with acute myocardial infarction or chronic heart failure that is deteriorated into cardiogenic shock? These distinct phenotypes have slightly different prognoses and have slightly different patient characteristics, although they may present in varying degrees of severity. So we still use the Sky Shock stage to gauge and determine how they're doing, but it's important to recognize what kind of shock patients are presenting with, and also to what extent it affects the right versus left ventricle or both. Now, Dr. Naidoo, in this nice review in the Journal of the American College of Cardiology, has proposed that not only is phenotype and etiology important, as well as shock severity, but the risk factors that accompany the patient also contribute to prognosis. So we're now getting to the stage where we can sort of really put all this together and try to make sense of it. The most disappointing part of cardiogenic shock research has been the paucity of randomized clinical trials data supporting any particular efficacy to any of the things that we do. It's been a really frustrating endeavor. The only thing that's really been proven to work definitively in a randomized clinical trial setting is myocardial revascularization from the initial shock trial. Now, we've got some important trials that will be coming out, including DanGER and RECOVER-4 in the future, but pretty well all the rest of the shock trials have been negative. And so this has really vexed both clinicians and researchers and created some opportunities for improvement in the future. So the guidelines, at least in Europe, suggest that in green, emergency angiography and revascularization should be considered for the culprit vessel in acute MI shock, fluid challenges, diuretics, invasive monitoring, and of course, ventilatory support. In orange, 2B and C indications include use of a pulmonary arterial catheterization, catheter to measure hemodynamics, inotropes, vasopressors, ultrafiltration. But as you can see in red, there's no real indication for routine PCI of a non-infarct artery or for routine balloon pump in all cases. So where are the treatment gaps? Really, where the treatment gaps lie in particular is in mechanical circulatory support, the timing, device selection, and patient selection, in addition to revascularization controversy, device controversy, pharmacologic controversy, and role of systems of care and specialized shock teams. So I wanted to spend a little bit of time just talking about the various devices that we have and how we go about thinking about how to match the device to the patient. As you can see, at least in the United States, we have 6 devices that are available to us: the Impella RP, Tandem Heart, VA ECMO, the balloon pump, Impella, and Tandem Heart from LA to femoral artery, both the Tandem Heart on the right side and the left side. And you can see here there's significant differences in flow support, ranging from 0.5 for the liters per minute for the balloon pump up to 7 liters per minute with VA ECMO. And you can see that there's differences in unloading characteristics. Very important to think about. in addition to afterload. Note that VA ECMO increases afterload significantly, thereby often requiring some venting mechanism for the left ventricle in an effort to reduce that afterload increase. Now, Impella and balloon pump tend to be very good afterload reducing agents, as well as to some as well tandem heart slightly increases afterload. These are all considerations that one must take into account when trying to match the device to the patient. This is just a cartoon illustrating the various chambers that are being supported and by the various devices available. And of course, it's important to understand the pressure volume loops and an understanding of how these various devices affect both preload, afterload, and stroke work. And you can see from these various illustrations that they have different effects, but for the most part, most of these devices reduce work of the ventricle. One of the most important things that has really hampered the use of these devices has been the complications. Early complications with cardiogenic shock and device deployment include systemic inflammatory response, acute kidney injury, vessel-related complications from access, circulatory complications, bleeding, and thrombotic complications. And then as the devices stay in over a longer period of time, we start to get into ICU-related complications and infection. This has really cemented home the importance of deploying the right device at the right time or only as necessary as is needed, and then removing the device promptly thereafter. So how do we actually incorporate these various devices into our treatment algorithms? At the Innova Heart and Vascular Institute several years ago in 2016, we really did a deep dive study into our cardiogenic shock patients. And we realized that there were 4 major problems that compromised care. One was fractured care, where care was interrupted or not seamless, especially in transition from one hospital to another. It was late detection. Patients might be detected hours after they are actually in cardiogenic shock. There was impaired access to care in some cases. And then there was large amounts of variations in care, inconsistency in the way that we treated patients. So we went on a really vast effort across our entire healthcare system to try to attack each of these 4 root cause problems that compromise care in our patients. And we've gone through multiple iterations of our cardiogenic shock algorithm. This is difficult to read, perhaps, and the slide may not project well, but suffice it to say that currently when a patient comes in with cardiogenic shock, they're immediately treated in one of our intensive care units. There's a rapid assessment in terms of physical exam, history, hemodynamic assessment, lactate, cardiac power assessment, and pulmonary arterial, there are PAPI assessment, and then we determine if the patient's refractory. If the patient's refractory, we immediately start thinking about 2 things. What form of shock is this? Is it biventricular? Is it left ventricular dominant? Or is it right ventricular dominant? And then we also think about the phenotype. Is this heart failure shock, or is this acute myocardial infarction shock? And as you can see from this somewhat complicated slide, there are various ways in which you can get at this relatively quickly. And then using the data that we have available to us, we try to match as best as possible the device to the phenotype and severity of shock, and also the form of shock in terms of RV, LV versus biventricular. So for example, in a patient who presents with heart failure and predominantly left-sided shock, we might go with a balloon pump or Impella 5.5. In an acute MI patient presenting with the same form of cardiogenic shock, SCAI stage C, we're more likely to use Impella in that circumstance, usually Impella CP. And we found that matching the device to the presentation has afforded us a little bit more ability to use our resources more efficiently, and at least in our hands, improve mortality over time. So I'm just going to show you a little bit of our own personal data using this algorithm. We have 43 hospitals that send their patients to a level 1 shock center at Fairfax Hospital. Level 1 shock centers have all the devices available to them, cath labs, and of course all the MCS devices Level 2 have a cath lab, but not advanced care and advanced devices. And level 3 centers basically are community hospitals that don't have cath labs. We have a one-call system where all these hospitals can dial one number and immediately emergency services are deployed, transfers are made, patients are brought to the cath lab if necessary, early myocardial revascularization is undertaken, hemodynamics assessed, lactate, cardiac power output and PAPI measured, and then we try to understand what MCS device, if any, is appropriate, and then we admit them to hospital. And using this kind of treatment algorithm, we've seen a significant improvement in our mortality since 2017. In 2016, our baseline mortality was about 50%, and survival to discharge now with this algorithm has improved to nearly 80%. We're pretty well hovering between 70 to 80% survival, which has been a significant turnaround over the last 5 to 6 years. We've published this in multiple journals, and I encourage you to read a little bit about the algorithms that we've used. We found them highly effective and very helpful. But I'll conclude at this point by saying there exists significant heterogeneity in the treatment of cardiogenic shock, not only across various regions, but across nations and continents, depending on device availability, standard treatment practice, and honestly, a lack of complete understanding of how to treat these patients most effectively. The current treatment paradigms that exist that are most modern and most well-informed tend to emphasize early detection, immediate staging of cardiogenic shock, phenotyping into acute MI versus heart failure shock, serial assessments, and then some standardized hemodynamic guided deployment of MCS as needed. Now, we don't have any good randomized trial data that underpins these decisions, so we have to just make the best decisions that we have available to us and also match that to the devices that we have available within our offerings. Team-based treatments that match cardiogenic shock presentation to the device have been, at least in our hands, been shown to be associated with gradual and steady improvement in outcomes for our cardiogenic shock patients. So I would emphasize the value of teamwork. You've got a wonderful football team in your country, and I wish them all the best of luck. But also, we've got a terrific team in terms of our cardiogenic shock team, and this is indeed a team sport. And without a successful, cohesive, collegial team, you're really not going to get anywhere. This is as much of a team sport as football. So thank you very much for your time. Congratulations on a successful meeting, and I hope to be able to come back and visit you in person next time. Thank you. I'll stop.